So our last speaker, before we open to questions, is Dr. John Flannery. John Flannery is the medical director of the Musculoskeletal program at the Toronto Rehab Institute on University Avenue, part of the University Health Network. He's also the head of the comprehensive pain program there and recently developed a novel research program, the Toronto Research Pain Institute. So he's a really important part of the management strategy of AS, because as rheumatologists we're pretty good at treating inflammatory disease and inflammation, but there are many occasions when pain is the central challenge and the central domain to be conquered, and we really value John contributing to this discussion. So welcome, John. Thank you.
Is our IT person able to come and help set up? Oh, he's coming. Here we are. So, before he gets this set up, just a show of hands of who knows what a specialist in physical medicine or rehabilitation is. Or podiatry is the American slang term that they came up with. So if that had been maybe a decade ago, then not too many people would have put their hand up. But interestingly, it's one of the oldest specialties in Canada. Started after World War II, which after the last couple of days, there's been an awful lot of talk about World War I and II. After we could keep people alive from those devastating injuries, we realized that you need a team. And so a lot of what has been said so far tonight is actually my talk. So Gerald, Bob, Nigel, Laura, Susan, thank you. I'm done. It was great to hear all those things, because actually I'm going to reiterate an awful lot of what they've said in this talk. This is really what's new in the treatment of chronic pain. Not too much, except maybe cannabis. Right? Cannabis is now legislated, and that's a big area of interest. I'm not going to spend too much time other than sort of say we need a lot more research in cannabis. It's really a bit of where opioids were about 40 years ago, and so we need to be very cautious in how we move forward in that. So, disclosures. I have none. I am the operations lead also for the ECHO project, which I'm going to speak a little bit about. I did have some nice handouts and pens to sort of give to you guys, but the taxi took a wrong turn and got me so frustrated on my way over here that I left them in the cab, and they're gone somewhere around the city. But if you do need some information, there's certainly our website is very well tooled with some of the information. So, outline, I'm going to talk about chronic non-cancer pain, the background, some of the treatments, medications, therapy, the interprofessional care, some interventions, then the education piece, because I think it's a really important aspect, because one of the most important aspects, to be honest with you, for what's new, is around education. We need to get the information out and translate it into the family physicians and the practitioners to help individuals with chronic pain. It's a lot bigger than the little program that I have or the network that we've created across Toronto called TAPME, Toronto Academic Pain Medicine Institute, which looks at multiple different academic centers, or the Adult Pain Network that I sit on for the province that looks at all the academic centers. So education is really one of the key areas. So here's the, I give the last one of our cycle of 21 for our ECHO project, which are little mini didactics that we do on this educational forum that I talk about. And this is that sense of awe. So wonderful, just wonderful. So much for holding the whole group in a sense of awe. So here, this is me falling down. I'm human, I fall down all the time. It's a real important aspect to understand that a lot of these things can be done by many of the team members. I just happen to be representing one of them as the medical director and a physician that works in that team. But every single member, like our physiotherapists, our occupational therapists, our social worker, and so on down the list, is critical to the management. And what does work in chronic pain? Interprofessional teams. The difficulty is trying to get that message out. That's where ECHO comes in, because it can actually get it out into family health teams. And the ECHO now actually has a rheumatology one that Claire Bombardier and Amanda Steinman, who are a couple of rheumatologists who work with us, have actually got an ECHO to try to educate family physicians in underserviced areas, which can be Toronto, because if you have to wait 6 months to get to see a rheumatologist, that's far too long. Or it can be rural areas where there really just aren't any of the specialists. So this is now to get you to understand chronic disease. So back pain, right up there. And I better put on my glasses here. Arthritis and rheumatism, also up there. So you guys have a couple of areas that cover the biggest part of chronic conditions. Ed Wagner, in a landmark sort of paper back in 2000, talked about a couple of important things of how to manage chronic disease. So the people and the process is sort of the summary of what you take out of this. So the interprofessional team, as I mentioned, is critical, and it can be broader than just those other areas, but we have a chiropractor who works in our areas. We have PSWs, we've got OTAs and PTAs who can also deliver an awful lot of information. Interspecialty care. So that's some of the stuff where Bob or Nigel and I, or the psychiatrists that I work with, we get together and manage this as best we can, because it's really important. As you've seen all these little Venn diagrams of this overlap between psychiatry and pain, and mood and pain and anxiety and pain, it's huge. So I can't do this without really good understanding of what my psychiatric or psychological colleagues are working on. And the same goes with our social worker, who provides an awful lot of support for that. So interspecialty is another key component. I've worked with plastic surgeons on burns, because burn has an awful lot of pain. And it's really helpful to have the two. I've worked with Raj Ramprasad on spine, and the two of us collaborated. I actually came and worked with him for a year in a clinic once a week, where he helped me understand spine better, and I helped him understand rehab. The same happens with the geriatrician. As we age, we get older. Arthritis becomes more. These conditions become more prevalent and more problematic, and dementia starts to come into these equations. And mood, as we get more isolated and we lose our loved ones. So there's these overlapping Venn diagrams which are important. And the process, you need population management. It's not just one drug, it's not just one intervention of therapy, it's all of these things. You need protocols on how to do it. Self-management is critical, and intense follow-up, because people get started, but then we've got to follow them and help them, usher them along. So this is a quote from one of the neurosurgeons that I met back in my first year of medical school, John Marshall, a lovely Scottish guy, and he said, pain, it's the friend that warns you and the enemy that destroys you. And when it gets dysfunctional, it becomes chronic. The context of chronic pain, it's confusing and complex. It's kind of like hitting a moving target. Things change, patients change, they age. So it's constantly adapting, which is the reason for the follow-up, which is critical. The research is changing, and constantly we're seeing different things that we thought weren't all that helpful, now are helpful. When I started medical school, nutrition was just something that was off on the side. Now it's become critically important, because we know that the things we put in ourselves can actually affect how we feel. There's many opinions too, and you need to be cautious around this. Physicians can generate an awful lot of money when they do procedures, and people who are desperate may want some of those procedures. So it has to be tied to the goals that Laura talked about. It really has to be tied to goals, because getting your pain down isn't the answer. It's making you functional. So we have to really focus on that. And people often use this visual analog scale. How's your pain today? Well, it's an 11 out of 12, or 11 or 12 out of 10. And that's what people feel. So that tool is no longer all that useful. So you have to keep that in mind when we're looking at it. This is how physicians feel. Chronic disease patients, they take up, they're 20% of my population, but they take up 80% of my time. So we have to be aware of that fact, and so that's where the education comes in. It affects about 20-25% of the population. Seniors, as they age, become even more so. It's a very costly event, particularly in all Western economies, because in states, for instance, it's billions, hundreds of billions of dollars. This is frightening. Training. So vets get 87 hours. And med students, maybe 16s, GPs in their training about 3.5. Scary. Absolutely scary. So guess what comes from that? An opioid crisis. Because it's like giving a handgun to a 4-year-old without showing them where the safety is. Right? So here's some medications. A lot of this stuff. So here's some, and there's 5 pieces of information here. 15 to 30% of the population are in chronic pain and are using opioids. We're number 2 in the world. Canada ranks 2nd, only the US, per capita of consumption of prescription opioids. Scary. Family physicians, dentists account for about 55% of how this gets started. First Nations, as we know, a very vulnerable group. Very, very vulnerable, and it's complicated. And opioid deaths, well, it's just rising. Again, this is the opioids and how much it gets prescribed. 9 million prescriptions were filled in 2015-16. 9 million. There's only 14 million in Ontario. So that's scary. And SARS, here's the deaths associated with this. Who remembers SARS? Right? My first day of practice at Hillcrest, or Toronto Rehab Hillcrest site, I was slated to have my first clinic, and it got canceled because of SARS. So I remember it very well. That was, really shocked Toronto, shocked the world. 44 deaths, and here we are with 638. People remember it. This is that quiet little killer that's been growing year after year and now become quite involved. Here are some of the actions that we're taking with this. So prevention, treatment, harm reduction, and enforcement. So on the prevention side, that's where Bob was talking about getting that early recognition for individuals with ankylosing spondylitis helps. You can get them into, remission if we get them early. So we want to get that diagnosis. So we have to get out the skills of management. So that's what Claire Bombardier and Amanda Steinman are trying to educate physicians and nurse practitioners in these rural, underserviced areas about the recognition part, so it doesn't take so long. Treatment, we've talked about that, gets you into remission, but there is no cure. We know that, so we have to then manage it. And we've already heard that chronic pain is one of the highest, as is mood, and sleep and other fatigue and aspects are right behind it. So no prevention, no cure. Treatment is improving. It's amazing, some of those new biologics. They come with a risk, though. The goal is to get the disease diagnosed quickly, for months or up to 6 to 8 years, which is what the average might be for people to get diagnosed, and that's a long time. Make sure you've got the definitive diagnosis, because it can get complicated. These areas sort of overlap sometimes, and then we're uncertain as to which one to go on, so they try to make sure, and then manage chronic pain if it exists or develops. So these next 5 slides are sort of the comprehensive approach. So this is from Andrew Smith, who's one of the individuals who works on our pain program. He's a neurologist who did some extra training and works at CAMH in addiction medicine. And so I borrowed these next 5 slides because he uses them as part of our little mini didactics for the ecosystem that we utilize. So assess, define the problem, diagnose it, other issues, the mood, the anxiety, the sleep, the addictions. Those are all things that Susan talked about. And then personal management and self-management, because I can't make the patients change. I can encourage them to change, but they have to do the work. I don't get them to take the medications. I encourage them to take the medications. So it's really up to the individual. And that's hard, because now I have to try to motivate them around some of those aspects. So pillar 1, comprehensive assessment. Horses are common, zebras aren't. The patients who come to our clinic have usually been seen by multiple individuals. I see in our group sees about 900 new consults a year, and we follow about 3,000 patients in our clinics. They've usually been seen by multiple specialists by the time they get to us. So if we can get to them a little bit sooner, it's helpful. Our average time in pain, unfortunately, is about 6 to 8 years that they've been in pain before they get to our clinic. So it makes it hard for us to make some changes, but we still have some of those benefits. So understanding the general history of low back pain. and using the core back tool, which I think Laura talked about, getting those core muscles involved, making sure that we do a neurological history to make sure we haven't missed anything. A lot of masquerading aspects can go on, or other diagnoses that are present at that time. And then a pain history, identifying the individual with the greatest risk of aberrant behaviors, because if there are opioids to be used in this, because they are also a great drug, I use them a lot because I get people functional. And once I get to the function, it's very easy to wean people down off the opioids. It's very, very easy. But we got to get them there. So pain is that barrier. We've got to get them over that barrier. Opioids are a very, very good medication. We just have to use them with the goal-focused behavior that Laura was talking about. We have to know what we're trying to do. And then, make sure we don't stigmatize them, because then people are very sensitive around the emotional aspects. So we have to develop skills in how to manage that. So the core tool is an effective tool just for people to use, and Laura's actually got us to do a bunch of those exercises right now that were geared towards some of that management, or demonstrated some slides. Pillar number 2, define the underlying problem. So we've talked extensively about that. We need sometimes to do investigations, but we need to be cautious about doing that because it takes time. And now we've delayed getting started on something because we've planted a seed of doubt that we need to. So once we've got the diagnoses confirmed, we need to move forward in this and then identify and educate people around what that looks like. Not everybody understands what inflammation means on an X-ray or an MRI, and it's very helpful. One of the aspects that I learned is how Raj Ramprasad explains to every single one of his spine patients just what's going on in that spine, and it's such an effective tool. If a picture's worth 1,000 words, you can imagine on MRIs, there's so much rich information, and it's sitting right in front of us. We just need to connect the patient, because now they know what's going on. The chance of them being motivated to go and do something about it is much higher. So education, again, is one of the key areas. Define it, nociceptive versus neuropathic. There's different treatment options that we can look at that. And then those other symptoms and conditions, the depression, the sleep, the anxiety, fatigue, sexual dysfunction, and addiction. I'm almost stealing this from my colleagues' slides. The personal responsibility and self-management. So interprofessional care, the refractory patient, and external locus of control are sort of 3 domains we talk about. So clinicians need to practice it. It's easy to say interprofessional care, but it actually means you talk to your colleagues and you find out what's going on with each one to sort of make sure. So I send emails to my colleagues to make sure I got things understood. And I speak to them about that. So Bob and I have talked many times, and Jill and I have talked many times to find out what's going on around certain patients. Now, it might be in an email traffic, but at least it's communication, because that's one of the things that we can leverage our technology. When you have someone that it doesn't work, there's a lack of buy-in in the self-management. So people often get to me without this stuff. So the first and best chance for good function is early on, before they've developed some of that recalcitrant nature that we cannot seem to move things forward. Provocative management versus proactive versus reactive. So it hurts. Well, if it hurts, your anti-inflammatory may be helpful. If it hurts, an opioid medication may help you to participate more effectively so that you can get that range of motion, maintain that function, get that posture established so that you're not fighting that each and every day. Those setbacks, flare-ups are critical. So now we have to develop some resilience underneath this to sort of say, yes, it's anticipated. So we don't lie to patients saying it's one and done. Back pain, you'll just have this one episode. It's going to come back. I guarantee you, your sore muscles are going to come back. But how you manage it is one of the important things. So don't stop. Keep moving, as we've already heard. And that external locus of control is a concept where we need to educate patients and families about the management techniques. It always seems to be something happening to them. We need to help them understand that they can control that and try to give them back that external locus of control internally. Opening your own internal medicine cabinet is one of the expressions that we use. So again, these are the types of goals we talk about. So I was pleased to hear Laura do all the SMART goals. And I have one of my colleagues, Mandy McGlynn, that she knows very well. She and I lecture on SMART goals, and we have a whole bunch of different ways to help people with it. But really, the underlying message, trust, rapport, and collaboration with your patient. Because if they don't trust, they're not going to do it. So I got to build that trust, and I make that explicit for my fellows and my residents and my medical students that are working with me, that that's what this is all about. Eye contact, understanding, listening to the individuals, because if you don't do that, the individual's not going to want to go do the exercise. They don't get it. So the motivational steps, it's another important thing. So engaging is critically important. You have to build that foundation, and that's the part towards trust. Focusing and clarifying the direction of what's on the horizon. So it's going to be a long journey. It's not going to be quick, but we'll be there. We'll continue to see you at intervals of follow-up, 2 months, 3 months, and keep moving, making some changes, because there's lots of things that we can do that we'll talk about, and then making sure that we get them towards the planning aspect. And how do we do that engagement? Or is this way of sort of navigating these murky waters? So open-ended questions. Affirmation. It's really important. People have to be heard about this and understood. Reflection. How is that getting you to move forward? I know it's difficult. Those mood issues are really problematic, but we need to engage in some of that activity for you to help move forward, to help make this pain better. Because the 5 things that work, for regardless of whether it's an inflammatory chronic pain condition or a neuropathic pain condition we've already talked about, but I'll just go over them. If you smoke, stop smoking. It's so prevalent, it makes pain worse. And it's not just like a little, it's massive how much. So I'll get off my soapbox. 2, if you don't sleep, we've got to try to make sure you sleep, because the sleep and the fatigue are very problematic. So that's usually another big area of focus, and not all of these are with medications. There's our other strategies, but sleep is critical. If you have limited range of motion, which we've already heard from Laura, get better range of motion, so that's the stretching. If you have weakness, which usually happens with the deconditioning, get better strength, and then cardiovascular fitness. So those 5 things are critical under all of this, and so that's where we start to look at how we can manage them more effectively. Crucial conversations. Anybody heard about crucial conversations? Put up your hand. So I'm certified in this. It's an area of interest, because how do you get people into that conversation quickly and effectively? So this is my little, pop culture kind of stuff. Start with the heart, right? Why? Because if you get your heart right, you know what's right for the patient, it makes it so much better, because then you're going to have your essence, your being, your presence is going to be there. So you have to make sure that their goals align with your goals, which are usually around trying to make them more functional. Watch and listen. Patients may not tell you everything that's going on. So you really have to just use your ears and watch your eyes. And physicians have forgotten a lot of this, right? Because they're telling you something. There's a message. And when you reflect back some of that stuff, they go, oh, he's actually listening to me. What the heck's going on? Most of my physicians don't. And so we really need to impart that. Control your emotions, because these patients have usually had a long time of pain and they want to get some of this off their chest. And we have to help them to understand that their emotions are going to play a big role, as Susan's already said. Your anxiety makes your pain worse. Your depression makes your pain worse. And these 2 feed off of one another. So we have to help that to understand it's physiologic. So the breathing technique, square breathing, is a very good technique at calming people down. So you just get them to breathe in, as we did with our arms, and then breathe out. And sometimes people get the hold. So there are techniques that actually work with the physiology. State your path. So this is what I think is going on. And as good as you can state your path, you then have to listen to theirs, because that's another piece that's important in this. And then once you get it, you get smart and you get an action plan. So we've talked awful lot about chronic pain. Now I'm just going to go into the treatment, the meds, the therapies, and the interventions very briefly. So management strategies: education, 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 and more education. Communication of diagnosis, so we have to be firm and commit to individuals so they actually know what they have. And there might be just an inflammatory point, or there might be this depression or this anxiety. And we have to talk about it, because it's going to impact. If we deny it, it's not that we're saying the anxiety caused your pain or the depression caused your pain, it's amplifying your pain. And so that's an important aspect. Goal-focused behavior, and so the SMART goals, we always say it's all about you. It's about your goals. And these things don't cost. Well, they actually do cost. It costs patients and family their time, and it costs the treating clinicians their time. So we have to understand that what we're trying to do and make it explicit, not just implied, but explicit. So we often give education. I actually get patients to sign the form because everybody grabs the information and it goes in the bucket and then garbage. But it's important. There's some really good educational tools. Our technology is fantastic. 23 and a half hours. Has anybody seen that video? Put up your hand. By Michael Evans. It's a fantastic video. You should just go Google it. I hate the guy. So he's down in Google right now. He used to work here in Toronto. He's a family doctor. You might have seen him on CTV. He was usually, or CBC. He was one of the physicians who was usually on, being interviewed by Peter Mansbridge. I hate him because he took all of my training and distilled it down initially into 9 minutes, and then down into 8, and now it's in about 6 minutes. And it talks about that 30 minutes of exercise that Laura was talking about. So there's some great educational videos that we need to take advantage of. So the drugs, opioid trials, after a good goal, focus on the trial to see if it works or if it doesn't work. So now we can decide, these aren't working for you. The non-opioid aspects are another sense, and there's a whole list of them. Tricyclic antidepressant, anti-seizure medications, SSRIs and SNRIs, they work because they talk in the pain center, which is right next to the mood center, and so those two interact. So they can be effective. And we're not saying that you're not able to cope and manage with these things, but we're just saying that that might help your pain become a little bit less so you can do more function. Topicals are another thing that can be quite helpful. We've got better compounding agents that actually penetrate into the nerves and go upstream inside the nerves. And cannabinoids, well, that's an interesting area. Like I said, we have very little information. We actually tried to do a randomized control trial that we're putting together as a group. There's so little information out there that we actually have to just do an observational trial. So our application to CIHR, big granting firm in Canada, is an observational trial because there's only about 8 good randomized controlled trials out there that have really only assessed about 200 patients. And this is now free to go, or available for everybody across Canada now. So we need to be careful because everybody's coming in and asking about this. And it has its place, no doubt about it, but we need to be careful. Interventions, again, it helps if there's some goal focus because, again, the nerves are smart. After we burn them or block them, the pain comes back. So it's a temporary relief. It might be 6 months, but it's only temporary. So again, we need to be able to sort of understand that it's around a goal. And then manage the comorbidities that we've already talked about. So here's the WHO ladder. This is where we progress up to management of different strategies. So we've got some science around this. Here's for the neuropathic pain that I talked about previously. These are some other medications where cannabinoids are on there. This is how we look at a multimodal approach. So we overlap these different things because one medication at a high dose might be really good, but a couple of medications at lower dose to decrease the chance of side effects might be equally as good. And so that's why we sometimes get people on a cocktail of different medications to try to manage the different sources of their pain. We've talked about this. It's really important, and this is just one slide that I've devoted, but look at all these different things. Exercise, psychological and education, manual therapies, physical modalities, and others. The others are really quite important. Ergonomic aids, braces, some meditation or acupuncture. These are all very good methods to manage it. And so it's really about taking advantage of all of these different things, but this takes time. The interventions, they help, absolutely, but they're not, the be-all and end-all. It's really around how to have that helpful towards these goals. So we usually talk about the 3 M's or the 3 P's. So the 3 M's, movement, mind, and medicines, or the 3 P's, the physical, the psychological, and the pharmacological. It's an overlap of all 3, and it's having a plan. So what is self-management? The individual's ability to manage the symptoms, treatment, physical and social consequences, lifestyle changes inherent in living with a chronic disease. So again, that's that internal medicine cabinet. Collaborations with family and patients are critical, so that's the family, our interprofessional approach. And now I'm just going to briefly touch on the ECHO project. Has anybody heard of ECHO here? A couple of people. It stands for Extension of Community Healthcare Outcomes. It has 4 pillars or 4 key aspects. It leverages technology So using these little phones that we have, we can talk to people all over the place in a structured format so that they can get education and do case-based learning. So case-based learning, they present the individuals who are participating, nurse practitioners, pharmacists, family physicians, they present the cases. It's the cases that keep them up at night that they're presenting, and we facilitate peer-to-peer learning, and then if necessary, a little bit of education from the hub. It's a hub and spoke model. Best practices, so we keep asking people to follow the best practices, and then we monitor the outcomes. And we've actually started to show already with our chronic pain, which was the first in Canada, that we've actually been able to show that family physicians' prescription of opioids come down with this. And we've monitored family doctors in the community, and their prescription rates really haven't changed. So the effect is there from our education. So the result, better care for more people. So that's really nice to be able to see it. So that's on the individual, but now we're teaching a family physician essentially how to fish so that they can get their own fish, and they don't have to rely on putting people into long waiting lists to see specialists. It started in New Mexico. Sanjeev Arora, he's a hepatologist, and people were literally dying to get to see him. So he lived in Albuquerque, and none of the patients there, New Mexico was number 49 out of 50 states for its outcomes with hepatitis. So he tried to change this, and he did change this. And he published a landmark study that got published in the New England Medical Journal around how primary care physicians who are taught and trained are just as effective as the specialists. So cure rates by both the spokes and the hub were equal. Except in another interesting, rehab closer to home, adverse reactions in rural areas were less than going to the specialty clinic in Albuquerque. This is the spread. Echo is catching on. The goal is to have 1 billion by 2025, so touch 1 billion people by 2025. It's in 31 countries so far. We got another 139 to get to. There are 11 super hubs. We're one of the super hubs here, so we train people rather than go down to Albuquerque. They can get trained here in Toronto now. We have 18 echoes present in Canada, or in Ontario, I should say, and there's another 10 sites all in the rest of Canada. So it's growing. High rates of opioid prescription and overdose and deaths. This is one of the reasons that we went at it. And here's our hub model. So this is us. And in the screen, you can see all the sites around that people can participate. So we have people from all over the province participating. We have modules, a curriculum that we follow. So there's 21 of them. And we focus on things like chronic pain fundamentals, opioid and addictions, special topics like diets and so on, special populations like individuals who are pregnant or pediatrics. We look at participants selected. The participants get to select things like myofascial pain or trigger points. So that's a method. This is where we've reached across Ontario, so it's working. This is who gets in. Physicians are the largest group, nurse practitioners. So we've really got some education happening to people who can make a difference. We also have some boot camps, so not everything can be taught over the web. So sometimes we need to have people get together, and it helps because now we form that team, and these people feel more empowered to become local champions of chronic pain in their rural area. And they teach us. They're so creative in these areas. They teach us each and every week, which is fun because then I'm constantly learning. So we facilitate this each week. So this is putting it all together, right? Update on pain. Education, education, education. It's really important. What ECHO does, it gives a knowledge translation. It builds capacity so that we can have more people who know how to manage it. It leverages technology. We've got great technology, and it's unbelievable. We have a librarian who participates. She posts things right afterwards, questions that they ask. They can get some answers right then and there. It takes 2 hours of their day, so they have lunch, and we have lunch. And then they go out and they see patients at 3 o'clock. It's finished at 2:30. By 3 o'clock, they're seeing patients. They implement the change right away. So this is a fantastic model for chronic disease management. It's in our rheumatology. It's in mental health. We've got elderly individuals that are also working at it because we have an aging population. Communication of the diagnosis is critical. You get commitment. You get our goals to focus on behavioral change. The therapy, we've already talked about, the medications, the interventions all have a role to sort of play, and we really have to manage those comorbidities. So the principles, get a really good team. create an interprofessional team with the culture that's there, get trust for the whole team and for everybody, and build that trust with the patients, and never forget that humans are humans. We have to understand that that's part of it. You need to master your patients with our patients, so we have to make sure that we focus on the people who are here, and then start with, the process is just goal-focused. Make sure that it's understand it's not an instant, quick fix. We are going to see you, and this is going to be over time. Keep patients accountable, and the patients then keep us accountable. And then when you have some of the patients that run into problems, you might need to spend a little bit more time. Thank you.